Everyone. So today again in this session I'll be discussing around 10 to 12 questions, and I'll be trying to take more 20 to 40 questions by the end of the day today. To I think 2 or 3 sessions more today I'll take. So in between any questions, stem or options, if you have any discrepancy, please let me know so that I can
Huh?
correct it itself and try to give you
Yeah,
the.
Red.
Yeah, so let's start. So the first question what I have here is that the middle and the lower thoracic esophagus is separated by. I think the options and the question stem is okay in this, and I think there is no issues in this. But please, for each question, if you can just let me know that if the question stem and options are okay, so that it's better for us to get a proper recall. So the middle and lower thoracic esophagus boundary separated by inferior pulmonary vein. So in this, very important see that this is mostly mentioned in the esophageal cancer portion of the Sabiston, which we also have covered in this table, wherein the middle thoracic vein, middle thoracic is actually between the esophagus and inferior, and the middle and the lower thoracic is separated by the boundary is the inferior pulmonary vein when the transition happens from the middle to the lower thoracic esophagus. So the answer here is inferior pulmonary vein. I think this question is pretty straightforward and okay. So moving on to the next question is, what is the treatment for pectus carinatum? I think this was a question, straight to a question, no scenarios or anything mentioned here. Anything to add on this question? Yeah. So I think this is again a very straightforward question, and this is again a very important thing that not very clearly mentioned in both the textbooks. But yes, we have mentioned clearly that for the pectus carinatum, out of the all the options, the best answer is modified ravage. Okay, it is basically a bilateral parasternal subperichondral cartilage resection for the same. And so here the answer would be modified ravage. I think these two questions, the option 4 was Cleget. Yeah. I think now the recall is more clear. Yes. So again, very straightforward question. Treatment for pectus carinatum is modified ravage procedure. Now, this question, I think, just help me out with the scenario, what I have mentioned, and the options here is a proper recall. That is a 72-year-old female with sudden onset lower chest pain, tachypnea, vomiting, fever, leukocytosis, inability to pass a Ryle's tube, and the upper GI barium study was performed, and findings are given as shown here. What is the most likely diagnosis? Is this okay? Yeah, vomiting I mentioned. Yes, vomiting was there. Inability to pass a Ryle's tube is there. Yeah, anything addition to the options and the question stem? Nothing, right? I think this was the pretty much a straightforward scenario. So here, because of the sudden onset, I would not be keeping diaphragmatic hernia as a differential in this question. With the X-ray also, there is an air fluid level in the chest, and this can be because of diaphragmatic hernia, but here because of the symptomatology I would not keep diaphragmatic hernia. It is an acute condition. Diaphragmatic hernia will be not presenting in such scenario. Air fluid level is never seen in perforation. Remember this, until unless, because here they have given that it is sudden onset and the patient has presented. So I would not be considering esophageal perforation here immediately. So malignancy is obviously ruled out because they won't present like this. This scenario is not typical for a malignancy. Malignancy in esophagocardiac junction were two different options. Can you just help me out with the options here? Are these options okay? Any issues or discrepancy in the options? Yeah, one option is malignancy, yes. So other option is esophageal perforation, diaphragmatic hernia, and gastric volvulus. So see, yeah, the thinking is correct that in terms of the vomiting with fever, tachypnea points towards you can suspect esophageal perforation, but here it is not the case because of the X-ray finding. B, C, D were there. Gastric volvulus was not there. Is it what you are trying to say? I think gastric volvulus was the option, right? Yeah. Yeah, okay. So here, because of the X-ray which is showing the air fluid level, most likely it being a stomach, I would not keep esophageal perforation. Air fluid levels are less likely seen in this acute setting. So large the radio opacity with the air fluid level which is seen. So I would not be considering esophageal perforation if this patient comes to me with the X-ray. I would be suspecting if the patient has and any retching, vomiting. I do a X-ray or a CT scan. There is a pneumomediastinum, and then I will suspect about esophageal perforation with some fluid in the thoracic cavity. That will give me a slight of differential for a perforation. But the air fluid level which is seen, I would not be considering perforation. First, obviously, on the base of the history and X-ray, you cannot pinpoint exactly, but as close or the primary differential, what I would be suspecting here would be a gastric volvulus, that is for sure. And another important thing which is pointing towards gastric volvulus is inability to pass Riles tube. This is another thing which they have specifically mentioned, which is pointing towards a diagnosis of gastric volvulus here. So this is why I would be suspecting, and my key here, I would be giving the answer as gastric volvulus, not malignancy, not esophageal perforation, and not diaphragmatic hernia. Okay. So here the patient can present with this is a Bota triad, which is classical, but there can be dysphagia, dyspnea, palpitations, the compression symptoms are there. And remember that in plain X-ray you will have, because if the stomach is filled, now remember why would there be an air fluid level? Because the stomach is fluid filled with air also. You have there is twist in the stomach, and that will appear as air fluid level. Remember that it will be a spherical glass gas filled viscous in the chest or upper abdomen. Remember, chest or upper abdomen, and there is a air fluid level. This is again a classical straightforward. They picked up a line, and it does not mean that if the textbook or the symptomatology or the classic triads, they are not present in 100% of the cases. So don't just pinpoint that there is vomiting, and in gastric volvulus you don't have vomiting. So I would not be putting it as that if it is not presenting with vomiting, then only I'll put it as a volvulus. Even if it presenting as a vomiting, there is sometimes suspicion of volvulus as well. So remember this, that this is very important to understand that a symptomatology or a triad typical what is given for any diagnosis does not 100% mean that if those triad symptoms are not there, you will not suspect that diagnosis. You need to rule out and evaluate the clinical scenario as well. So yeah, I'll be also marking this, and I'll be again going through the trying to see if I can give you a better clarity on this. But from here, what I have mentioned, I would be keeping gastric volvulus as a primary diagnosis, yeah, differential here, and I would mark that as the answer. Next question. Post bariatric surgery remission of diabetes due to, I think this was the clinical scenario, right? I think there is no issues in this. I think this was the question. That is, post-bariatric surgery, remission of diabetes occurs due to which hormone? Yeah, so this is again a very straightforward thing. This is from the Sebastian where they have mentioned about the enteroinsular and the enteroendocrine axis. So enteroinsular endocrine axis, it is very important that in the patients with metabolic syndrome, what are the hormones? What is the hormone which is important, which we target for during the bariatric surgery? That is the bypass surgeries, is the GLP-1, which is very important for the remission of the diabetes mellitus, and this is in the post-op that is required for the early diabetes control. So we have also very clearly mentioned in our that which of the following improves, that is related to the GLP-1 changes, that is type 2 diabetes mellitus. So here the answer is GLP-1. I think no doubts in this. A patient presenting with a RTA with pelvic fracture, suspected urethral injury with blood at meatus, investigation to diagnose urethral injury was the scenario. Any addition to the scenario for this question? Any addition of the scenario? Any addition to this? Okay, so simple question. Yeah. So here the answer is a RGU. Again, this is very typically mentioned in the all the books about what is a diagnosis, and we have also clearly mentioned that RGU is a gold standard in our notes. That is the urethral injuries. Remember, it should be done before Follies if the blood at meatus is seen, and this is why the answer is RGU for a suspected urethral injury, and this was very clearly taught also in all our classes and mentioned in the notes. Moving on to the next question, I think here some of you told me that in this question there was another some scenario given. Is it so, or only this was given that with histological finding will increase the relative risk for breast cancer? Any scenario or the question stem was slightly different in this? Okay, there was no scenario. Yeah, this was a stem that is which histological finding will increase the relative risk for breast cancer. So I think the answer is very pretty much straightforward that periductal mastitis is a ductal ectasia or leading to an inflammatory condition. So this both will not have, if we see the relative risk table also, which is mentioned in the Schwartz, and also what we mentioned in our notes again, that is any proliferatory disease will have ADH or ALH will have increased relative risk for breast cancer. Non-proliferative lesions will not have any risk. Sclerosing adenosis, intraductal papilloma all do not have. ADH has increased risk. So here the answer would be ADH because all the others are not having any increased relative risk for breast cancer. Was a description of BIRATS 2 given in this question stem? Was the BIRATS 2 description given for this question? Okay, I think that was different question. I think there were a few breast cyst or breast BIRATS related questions. So I think there is a confusion in that. Yeah, so here it is pretty much straightforward that ADH is having the increased relative risk for breast cancer. So moving on to the next question is, I think most common cause of either mortality is given or a peri-op or perioperative death given. What was the question stem? Was it a straight liner like this? Perioperative death. Okay, yeah. So most common cause of perioperative death after bariatric surgery. Most common cause of death, yeah, perioperative mortality. So here, very important that there is no pretty much straightforward mention about this. But if you go through and read, or I've gone through all three textbooks, and the closest one what I've found is related to the RYGB related complications, wherein they have given that pulmonary embolism is the most feared complications after any form of bariatric surgery, and thrombotic complications like DVT and pulmonary embolisms are associated with up to 80% of patients has evidence of PVTE, venous thromboembolism. So here it is not anastomotic leak, it is not bleeding, because both of this in bariatric surgery patients, because we do bariatric surgeries, we immediately go for a CT scan. Any suspicion we immediately explore. So the risk of mortality is very low, but pulmonary embolism or venous thromboembolism has a higher risk in the bariatric surgery patients because usually the mobility is less in this patient. So we go for a DVT prophylaxis in our all post-op patients. So yes, the answer here would be a pulmonary embolism or related to thromboembolism. I think the options are okay in this: cardiac, anastomotic leak, bleeding, and pulmonary embolism. No other change in this question stem or options, right? Yeah. So moving on to the next question, that is the most common congenital diaphragmatic disorder. I think is this was what was the one-liner given, or was it related to most common congenital diaphragmatic hernia? What was the question here, and are the options fine here? Now, why I'm confirming its question stem and options here, because even slight change in the question stem or the options can change the answers. I want to give you a accurate recall. Yeah, same question. So I think this is a very straightforward. Again, the answer is Bogdalic hernia. This is again, if you go through the mention in the thoracic portion of the lung or in the pediatric surgery, everywhere it is mentioned that the Bogdalic hernia is most common cause of pulmonary hypoplasia, and it is the most common cause or most common congenital diaphragmatic hernia or disorder, and which is related to the pulmonary hypoplasia. So the answer here is Bogdalic hernia. Now, I think this was the image what was asked, that which is the type of volvulus mentioned in this image. Any addition to the question stem here? Any addition to the question stem, or the question stem and everything is okay? Yeah, so yeah, we have clearly shown in our notes about the various types of gastric volvulus: organoaxial, mesenteroaxial, organoaxial volvulus. So organoaxial is basically longitudinal, that is axis of rotation is from the cardia to the pylorus, which is shown in the black line over here. And if the line passes along the greater and the lesser curvature, it is a mesenteroaxial. So most common is organoaxial, and the answer here is organoaxial volvulus. So I think was saying axis through the black line. Okay, the axis passes through the black line. No, the Savastan 21st edition image is incorrect. We have corrected, we have discussed it multiple times over last few years that the Savastan image is incorrect. So it is given reverse. So here the straightforward, if you have, I think I have also mentioned in the visual mastery classes as well about the incorrect image of the gastric volvulus, that this is the correct image. And we've also mentioned in our notes correctly that it is along the line passing through the cardia and the pylorus. So the answer here is organoaxial. Okay. Next, now here there is some discrepancy about yeah, theory part is correct in Sabiston, but the image is given wrong. Yes, that we have pointed out multiple times in all our classes and in notes also. So moving on to the next question is burns involving right arm circumferentially, bilateral leg and perineum. Was this the scenario given? Because even a slightest change in the word in this will change the answer here. Was this the answer question stem? Description was there, but the stem is right. So description was almost similar to this adult with right arm circumferentially involved bilateral lower limbs and perineum. I think if lower legs, yeah, lower leg or lower limb, I think there is some discrepancy in this, but yeah, as majority of you, yeah, so here I think so that if we see that right arm circumferential involvement, that is giving it as 9%, there is no difference between thighs and legs, bilateral legs means that it is a bilateral lower limb. I think you don't have a division that the thigh is 4.5 and leg is 4.5. It is not like that. It is a complete leg. Yeah. So still as per the answer here, it would be each lower limb, which will give 36%, perineum 1%, and the arm with 9%. So here, according to me and the recall and the Wallace rule of 9, the answer would be 46 here. Okay. So here there is some discrepancy about answer being 28 or 46, but as per what I feel is that we cannot ourselves, if see bilateral legs mean that they are completely involved. I think there should have been some clarity on this, but even if you don't have this, yeah, I don't think in the Wallace rule of 9, if you see the image also, you cannot demarcate that if the legs are involved it is 4.5 or the thighs are involved it is 4.5, because usually because they will not have the division that the thigh is half and leg is half. So according to me, the answer here would be 46. I think there would be some discrepancy and discussion over this question, but uh, yeah, so if perineum is involved, that points out that thigh is involved very correctly, and that's why if I think there should be, I mean, clarity in the wording, but I think there's a very lazy type of question framing. But I think what they wanted to ask is about the lower limb involvement and the right arm involvement with perineum. So the answer here, see, if the legs do not have circumferential involvement, think logically that they're trying to ask you Wallace rule of 9. Wallace rule of 9 does not have anything like front half or back. It is involved. If legs are involved, means they want to tell you that whole legs are involved. If they wanted to ask that the front of leg is involved, the back of the lower limb is involved, they would have mentioned that. So you cannot particularly tell that, okay, if bilateral leg is given, should I count front or back? It is circumferential or it is complete involvement. Yes. Yes, very true. There's a very lazy question framing. I agree. This is not good for all of you. But according to me, as per the question stem, I would be giving the answer as 46 here. But just hope that so all of you who have answered 46, this is what they have mentioned, because I think this question is very lazy in the framing. So next, coming to what is the determinant of increased vascular permeability in fulminating E. coli infection. Now, I have gone through all three textbooks to find the reference for this particular question here. See, considering the burns in patches, you cannot assume. See, I've also told you many times when I'm teaching that please don't assume anything in the question until unless it is mentioned. If it is not mentioned, go for the generalized thing that what they're trying to ask. Don't try to assume things that they wanted to ask in patches and they wanted to calculate the area of the patch. It does not work like that. So now moving on to the next question, increased vascular permeability in fulminating E. coli infection. What is the determinant for this? Now I tried to find references in all three books. I could not find a very particular pinpoint reference for this. So I have gone through the articles, and the best answer here is glycocalyx layer of endothelium, which I have gone through, and this is from the article what I have tried to search, that the endothelial glycocalyx is a fundamental component of the endothelium and important determinant of mechanotransduction and vascular permeability in patients with sepsis. So here the best answer according to me from the reference what I've tried to search is the and glycocalyx layer of endothelium. And if any of the student for this particular question have found any reference from the book, please share it with me. I have not found it in Bailey, Saviston, or Schwartz for that matter. So which type of flap is shown in the image according to the Mathis and Nye? So this is gluteus, and the this is again a very straightforward. We have multiple times taught in all our classes about the Mathis and Nye being important and mentioned here. So I think there is no discrepancy or doubt in this. Any scenario was given or straightforward image and the question was asked. Yeah, so the answer here is type 3. So moving on to the next question, that usage of immunosuppressant causing diffuse coronary thickening. And I think this is post heart transplant, which is pointing towards cardiac allograft vasculopathy. I think this was the question for this, that which immunosuppressant causes diffuse coronary thickening or post heart transplant, that is coronary allograft vasculopathy. I think this was the question, Stan. Yeah, so here the answer is calcineurin inhibitor and have 1 year after heart transplant, yes. Okay, so 1 year following heart transplant, there is diffuse coronary thickening, that is known case of diabetes, underwent transplant. So see, yeah, diabetes was in the question stem. So diabetic patient undergoing a heart transplant after 1 year presenting with coronary allograft vasculopathy, which is a known thing. And in this, it is basically that it is a type of rejection. But another important thing, which they have not mentioned in all three books, it is that no, you cannot correlate that mTOR inhibitors leading to hyperlipidemia, leading to coronary thickening. This is not the coronary thickening of atherosclerosis or hyperlipidemia. This is the diffuse coronary thickening, which is pointing towards a coronary allograft vasculopathy or type of rejection. And here, very important, I have tried to find the article for this, wherein it is very clearly mentioned that after transplant, because we start with the immunosuppressant, there is a evidence that calcineurin inhibitors, they are associated with endothelial dysfunction, and it can lead to progression of the cardiac allograft vasculopathy. So in this, it is important that we reduce the dose of calcineurin inhibitors. Yeah, clinical stem showed heart transplant, follow-up after 1 year, thickening of coronary arteries. Which agents? The answer is calcineurin inhibitors. Now, there is no straight mention about this particular pathophysiology, that because of the endothelial dysfunction due to the calcineurin inhibitors, there is exaggeration of the coronary allograft vasculopathy. So here I've gone through the articles, and there is a particular link between calcineurin inhibitors and progression of coronary or cardiac allograft vasculopathy. So here, then we need to switch from the calcineurin inhibitors to sirolimus or everolimus. So your answer is calcineurin inhibitors. There is no other answer of mTOR or azathioprine or corticosteroids. So the next question, that is about epidural hematoma, was given, or the EDH was given. The length is 12 centimeter, the width is 2 centimeter, and it is seen on 10 CT slices, which are each 5 mm apart. I think this was the exact question stem which was asked, and they were asked about the volume of bleeding. Yeah. So here the answer is 60 ml, and this is according to the ABC2 criteria for the intracranial hematoma sizing via CT scan, wherein we multiply the length into breadth into C. What is C here? It is basically the number of CT slices into the slice thickness in centimeter, and accordingly, the answer here is 60 ml. I think very odd question for NEET SS per se, but they have a habit of asking such questions in CTBS, specifically cardiothoracic and neuro. So here the answer is 60 ml. I think many of you must have skipped this. Even I would be skipping it if this had come during my time, because this is not something which you read regularly. But here, yes, they have asked. The answer here is 60 ml. So, so just quickly going through the questions once more, quickly sharing you the answers for each question what we have discussed today. So here, first question is about the middle and lower thoracic esophagus boundary separated by inferior pulmonary vein. Pectus carinatum treatment is modified ravage procedure. Patient with vomiting, inability to pass Ryle's tube, airfoot levels on the chest X-ray, and old age female. The question answer here, according to me, would be gastric volvulus. The post-bariatric surgery remission occurs due to GLP-1 analog, GLP-1. Then you have the pelvic fracture, suspected urethral injury, blood at meatus. Investigation to diagnose is RGU. Then you have the risk factor for breast cancer, which increases the relative risk of breast cancer. It is ADH. Most common cause of perioperative death after bariatric surgery is pulmonary embolism or venous thromboembolism. The most common congenital diaphragmatic disorders among this is Bogdale's hernia. Then you have the types of volvulus asked with the axis passing through the black line, that is cardia and pylorus, that is organoaxial type. Circumferential right arm involvement, bilateral leg involvement, perineum. Here, according to me, the answer would be 46. Determinant of increased vascular permeability in fulminating E. coli is glycocalyx, layer of endothelium. Math is night type 3. Then you have immunosuppressant causing diffuse coronary thickening, that is calcineurin inhibitors. And lastly, EDH calculation given, the answer here is 60 ml. So I think this is it for now. I'll be taking another session most probably in the evening with the next set of questions. So if you have any other discrepancy or if you have any other questions, STEM and answers which you can share with me, please feel free to share so that I can take the next session as soon as possible and try to cover more and more questions to finish it off as soon as possible. Yes, I'll be uploading this on the YouTube in some time. So that's it for now. Thank you all for joining.